I'm Kieren. I'm an ophthalmologist from the UK. I'm very fortunate. I've got my own SCHWIND system, so I've got the ATOS and the 1050 RS, and so for the last few years I've been using them with great success. But they asked me to talk about allogeneic intrastromal ring segments, obviously with the introduction of rings now being possible to do on the ATOS, just to talk through it, and that's exactly what we'll do. So we'll just review it now. So I've got no relevant financial disclosures for this talk at all. I pay SCHWIND a lot of money, they don't pay me money, so it's yeah. So look, we all know what keratoconus is. It's a very common disease. It's potentially increasing in prevalence because of an increase in atopic eye disease around the world. If you look around the world, the incidence varies, but across Europe, sort of very similar between countries, but there are places like Australia where it is higher, probably because of allergic eye disease. We also see a difference between races, and so this is UK data, and you can see it's a 4.4 to 1 ratio difference between Asians and Caucasian population. So what are the principles of irregular corneas? Thankfully, you've already had a talk just now about managing an irregular cornea in the terms of the 1050 RS, which is unsurpassed with any other laser system around for doing what it can actually do. But the two tenets of what we're trying to achieve for patients are, one, to improve their quality of vision, and the second one is to try and prevent progression and to stop things from getting worse. And so if we can combine those two things together, then that's a very positive thing. And just to take a step backwards, I think the one thing that we all as ophthalmologists fall into a trap with is we all think about Snellen visions and high contrast Snellen visions. Whereas actually that's not the world that we live in. We live in a world full of color and contrast. And so we are trying to improve the high contrast images, as we can see here, but it's also reducing dysphotopsias and improving low contrast vision. That's equally important. And actually for many of the patients with their lifestyle needs and desires, that becomes more important actually. So we want to try and achieve both. So what are the tools we've got available to us to date? We've heard about some of them today. Well, essentially with the corneal treatments, we can remodel it, we can subtract and take tissue away from it, or we can add tissue to the cornea. And so they're the three different modes. And we've got lots of different ways with customized cross-linking now just coming to action with Boost and potentially with Pace. But then obviously with the transepithelial topo-guided ablation treatments with either corneal wavefront driven or ocular wavefront driven with the 1050 RS. And now with the exciting introduction of Foresight, which has really changed the way that I'm now delivering these treatments, and particularly in my preoperative planning with them, it really has made a big difference. As far as additive techniques go, we've got intrastromal corneal rings, which we'll talk a lot about today, but there are other ways of doing it with lenticules, with Azenia, which you'll see around here, Bowman's transplants, and DALK PK. And in the risk of being controversial, I'm going to cross 3 out that I don't think are quite there yet. And so that leaves us really with the adjuncts we've got, with the DALK PK being the fallback position that we've all had for the generations that we've been doing this. So what about keratoconus and the progression? Well, we know that with time and with it being undiagnosed, and historically before the advent of collagen cross-linking, we used to just have conservative measures. So stopping eye rubbing, treating allergic eye disease effectively with the adjunct of potentially of lubricants. Collagen cross-linking changed that in the UK in about 2012 when it's first introduced. And we've now got a treatment that's around 80 to 98%, depending on your population, effective in stopping progression. Long-term data we still don't know, and we are starting to see a few patients now that are getting hyperopic shifts and peripheral progression about 12, 14 years down the line, following having their first cross-linking, because that cross-linking effect is around the periphery. And so it'll be interesting to see over the next couple of years what actually happens and how that translates. But the visual rehabilitation is clearly the bit that patients are really interested in as well. And so, you know, we've got the conservative methods, and as their vision gets worse, from soft to hard to specialist contact lenses, and the technology's moved on there. And then historically we've had, and some people still are using with great effect, the acrylic rings. They had a more of a limited span though, being able to treat, you know, from moderately early to moderate, usually with limitations around Kmax is around about 56. And with thicknesses, with the US, with the FDA, 450 microns in the area you're putting it in. In the UK, 400 microns is always considered to be the safe zone. And so that left a lot of patients needing DALKs, PKs, and really having to go down that route. But now allogenic inlays really are an exciting new addition to our armamentarium, hopefully over time now. And now we've got available on the ATOS, it's even more exciting. But we can see, and we've had this for a while, but this is, as we said, progressing and progressing and progressing. And some of the things that I can now do on the 1050 RS I could only dream about 5 years ago. It really is transformational. But there are still a population down at the end, hopefully a reducing population that still need to have corneal transplants. And you can see this is the UK data. It stops in 2017 because no one's actually, because of COVID, actually updated it. But you can see there's been a drop-off in the UK, the number of transplants done now for keratoconus, with the advent of DMEC and other endothelial grafts actually really increasing the proportions there. Obviously, there are patients that we can't do anything else with. Patients with previous high drops, with scars, they still need to have the transplant, and it still works very well for them. But a larger percentage of patients are young. They potentially have poor compliance with drops, and their incidence of allergic eye disease is far higher than a general population. And all three of those increase the risk of needing a regraft and a transplant failure or rejection. So if we actually look at the UK data for that, you can see that every subsequent graph has a drop-off in its Kaplan-Meier 5-year survival curve. And you can see from graph 1, we go from about 70-odd% right the way down to graph 5, where it comes down to 19%. Okay, so where did the use of allogenic tissue first get introduced? Well, interestingly, I was actually talking in Australia recently, and Rajesh Fogler was there, and he showed 2 very interesting Russian papers that dated back to 2014 that described the use of allogenic tissue very well, describing exactly the same shape segments that we're now using, and the technique they describe as bandage therapeutic optical keratoplasty. And here's the second paper, and you can see here this one's from 2015 in the Russian literature, but obviously didn't get more widely accepted because it was only written in Russian. But you can see the use of an allogenic implant to try and correct irregular astigmatism. So the term CAIRS really came from corneal allogenic intrastromal ring segments from Susan Jacob. And that was around about the same time, 2015, when those papers were done. And she's really taken this forward and actually globalized sort of the use of this tissue now in CAIRS, and really pushed it into everybody's front of their mind, actually, when they're considering treating keratoconic patients. It obviously follows Barker's law of thickness. So as we increase thickness in the periphery, we get central flattening. So how do the early results? And we're still looking for long-term data on this, and we haven't got long-term 10-year data on any of this at present, but it is starting to filter through. These are low numbers. This is from Susan's group, and you can see actually if you compare it against the Intacs, so one of the acrylic brands, actually the improvement in corrected distance visual acuity, the improvements in topographic astigmatism between the 2 groups in the Kmax, and then also in the are all very comparable. Interestingly, and something we'll talk about a bit more, actually the compression above the actual implant that we know with the acrylic rings, with a greater compression, led to an increased risk of actually extrusion of those grafts. But you can see with the CAIRS tissue, we're actually getting more compression, certainly from this study, and it's something that we need to all be mindful of. So what are the advantages? Well, the advantages are it's more biocompatible. Okay, so stroma implant is not an acrylic implant, and therefore there's low risk of foreign body reactions, of lipid keratopathy, and vascularization of the actual implant itself. It's optically less refractile, so there's less dysphotopsias, and so better tolerated by patients. And it also allows more customization. So we can now actually customize, rather than having an acrylic fixed ring, we can actually change the shape of the ring as the surgeon on the day of the surgery and reshape that tissue to be able to give a greater level of customization for the visual improvements. So we've already mentioned the less extrusion. We know with the acrylic rings, there's risks of corneal thinning, melting, extrusion of the sections, and depending on the paper you look at and the literature, from between 1 in 200 to 1 in 30 explant rates. Whereas we've seen from the early data that allogenic implants have less of that, they're more biocompatible, and they're integrating better into the cornea. The effect also is arguably greater. One of the main restrictions, due to mainly because of the deeper placement that was required for acrylic rings, was that allogenic rings now can be placed more superficially, and so up to even 250 microns. We know that the anterior third of the cornea has more biomechanical strength, and actually the higher and the more superficial we place the implant, actually the greater the flattening effect centrally we have. And so actually with this tissue being more biocompatible, we can now start to lift this, the level that we're actually implanting it at. And we can also implant larger volumes. So the Kieren Natural, which we'll talk about in a second, comes as a full thickness graft. So you can actually put 550 microns of tissue into the cornea, and actually that then has a much greater effect. So the lower extrusion rate also allows us to have a wider range of indications. So now we can use it in more advanced keratoconus, and I'll show an example of where I've done that, where we can actually, less than 450 microns in the zone we're putting it in, but also now K is greater than 56, because this can be used in combination with other treatments to now get the final visual result that we actually want with patients. So, and one example I'll show you later is combined with the topo-guided treatments to improve that final result, and it works very well together in combination. So what about the planning about the surgery? How are we going to work out exactly what we're going to do, the thickness of the segment we're going to put in, and what we're going to do? So the first question to ask ourselves is, where is the steep area of the cornea? And the simplest way to do this is to literally draw a linear line through the cornea to divide it in half, and then if it's all steeper inferiorly, that's where the segment wants to go. So we cover the segment here. This segment's not quite big enough. You'd expect it to cover around here and be a slightly larger segment than the one drawn there. And then one or two segments. So in that last example, that's a great example of where one segment will suffice. So we do our line. If all of the steepening is on one side of our line, then we just need the one segment. If, however, as in the next example, we start to draw the line and actually have steepening on both sides of the segment, then that's the example to start implanting two segments. So this is from Dave Gunn, who was one of my ex-fellows, who's now back in Brisbane. And he's done some work with customization of the CAIRS implant and done quite a lot of the work and really pushed things forward actually in Australia and actually for the rest of us. But this is one of his examples that he showed where we've got a very asymmetric cone, which is not uncommon. So if you follow the same principles as we've done before, what we'll actually see with that cone is that we're going to get an overcorrection on one side and an undercorrection on the other side. So what actually allows us to do now, being able to reshape the tissue, you can see the overcorrection area there in red and the undercorrected area there in green, is that we can actually now taper the edge of that. And here's one of Dave's cases that he actually did, and you can see the tomographic effect and the improvement you get with that customization, avoiding that overtreatment in one zone, and therefore not creating more irregularity because of the treatment itself. So they've designed a CAIRS plan, which actually works amazingly well. And I have to say, I've started using it myself. They've been pushing me for a long time, and I have started to use it now. But it's actually a very simple tool that works to be able to upload your tomography. And then you can actually then do your planning by changing parameters and then trying to see the outcome and the effect. And for GDPR reasons, they don't keep any of your data. There's no outcome data associated with that. And so you can export then your plan as a JPEG or as a PDF, and then use it for your surgical planning. And here's an example of exactly that. Okay, so how about the tissue preparation now? And this is half the problem with this sort of tissue. We are often trying to squeeze and shoehorn something into a very tight space. And we know that actually the tighter the space we get in, the more predictable the result we're going to get. So what we want to avoid are massive channels where we get remodeling of that tissue and spreading of the tissue where we lose some of that effect. So there are two types of corneal trifines. So they've just changed my things, but there are essentially manual ways of doing it, and this was the original way that we all started doing this by doing two trifines, one on the external, then having to position the central one for the second one, but actually getting that alignment correct can be a problem, and so you can then very easily malalign the two trephination points, and it's something we're used to with the Boston Cape Pro. It has the same problems, but now been overcome. And so now Susan helped to develop the Jacobs trifine, which is actually a double trifine, so you can now get both in one, so it avoids all of the unnecessary risk associated with that. They come in various different blades as well, so you can actually change it, but there's still no nomogram. But the pre-cut segments have now made this a far simpler solution. So they're now increasing numbers coming to the market. The Keratoconus is 1 millimeter wide, and that's something that's important with your planning to understand. But then they come as full thickness corneal grafts. So you can then have the ability to customize and to tailor exactly what we're trying to do. They're all irradiated and stored in albumin, so they've got a 2-year shelf life. But the other advantage of that is there's less risk of rejection and failure of this tissue, and it increases the biocompatibility of it. So it's able to customize, as we've said. So how do we insert it? Okay, and this is the key, and this is something we're all still probably learning, and there are various different techniques of how to get this tissue in. Jack, on his videos, if you've seen them on YouTube, shows beautiful examples of how he makes it look very, very simple, and it takes you back. And he just does it in a very standardized way, in the way that we've all done with the acrylic rings in a manual method, by finding with a suction trifine a way to do it, and then doing a manual trephination in the cornea. But we know there are problems with this, that you can end up with superficial placement, you can end up with perforations, and you can end up with the problems that that we all know about from the other rings. But then he dehydrates, which is a great way of actually implanting this tissue, because the dehydration shrinks it and it makes it far easier to put in. But we'll talk about that in a second. The key thing about the dehydration is there's lots of different ways to do it. We're very restricted in the UK, because if you want to have the tissue outside of its packet for any length of time, it needs to be in a room that's got 25 air changes an hour. And so it has to be done in the main theatre. And most of us don't have laser platforms in our main theatres, and so that does restrict how we're doing it. So Rajesh has described boiling water in one bowl and then placing a second bowl on top to dehydrate the segment, which in his hands works very well. And there are now new air drying methods that are coming that are speeding this process up. And this is Dr. Haishi, who again does a very similar method, but actually not having access to exactly the same sort of trephines and to the same methods, uses a diamond guarded knife, and then actually just then makes a very mechanical insertion into the eye for a stromal segment by cutting a segment like that, and then you can just squeeze it in. So all of these in the right hands are very simple, very easy procedures, but we know for any of us that are training and teaching fellows that actually we're then fraught with complications and problems. And so actually these all work very well in experienced hands, but if we haven't got experienced hands, then there are easier ways to do it. And so this is a great example of a superficial placement. It actually biointegrates and does well, but thankfully SCHWIND came to help us. And so with the ATOS now, we've now got rings available on the ATOS. And you can see there's ATOS rings being made on ours, and that was the first one we did actually. You can see my suction is probably not ideal, and that's an issue that actually we're having to face now, because actually when you're dealing with a cone, actually getting the same level of suction with the machine is actually increasingly more difficult, and that's something we're still learning how to improve and to get better all of the time. So I'm just going to very quickly talk about the principles of the channel formation, because the original papers that actually describe the technique even got this wrong. So this is just, I think, fundamental to understanding how to do it and how to design what we're doing. So we create two channels with a laser or manually, but with a laser. And say, for example's sake, we create one at 4.5mm diameter and a 7.5mm diameter. The actual channel width is not 3mm. So the channel width is actually half of that. It's 1.5mm. And so we've got to be aware consciously that actually our channel width is the outer diameter minus the inner diameter divided by 2. And so there've been a lot of people struggling to get them in, but by making narrow channels. More than that, when you've got a 1.5mm channel that you've actually cut, as soon as you start to try and shove the tissue in, you actually distort that channel. And so it's no longer a 1.5mm channel, and it actually decreases in size. And so we've actually got to just think about that with the amount of tissue we're trying to shoehorn into this area to try and work out exactly what sort of width of channel. And so is actually my first case on the ATOS from some time ago. But you know, we were doing very large channels there now. I've brought it down now from 4.5 to 8, because the problem with 4.5 is you can actually get too close to the visual axis. You get a much greater effect, but actually getting it too close to the visual axis can actually adversely affect the end quality of vision that you end up with. So this is the Istanbul nomogram, which you're probably all aware about, by Kieren. And so she standardized the tunnel size, the tunnel depth, and then just allowed the ring thickness and the length and the location according to the topo-guided topo to actually be the adjustable component. So by standardizing at 250 microns, making the same size channel, it does standardize the way it goes in. But again, Dave and Brendan in Australia have been trying to develop a more customizable nomogram where the cross-sectional area of the segment, the channel width and the optical zone that we're using are more customized to the actual degree of keratoconus and the shape of the cone that we've actually got. And so by having different segments that we can insert in different size segments, it allows a lot more customization in the way we can actually deliver the care we want. So I'm just now going to finish with just two examples. Okay, two real examples from my hands. You know, so there's no hiding in any of this. This is just two examples of cases that I've done. So the first one's a 25-year-old Asian female from the UK, came to me with severe allergic eye disease, very severe allergic eye disease, which we managed first. So we optimized her ocular surface, we managed her dry eye disease, we treated the allergies. She's myopic, became profoundly contact lens intolerant, and her unaided vision, as you can see there in the right eye, 3/60, left eye 6/18, but they did improve the subjective refractions in the right to 6/24 and the left to 6/12. But still unable to drive, wanted to be able to drive and didn't meet the legal requirements in the UK, and so wanted to try and achieve that to gain independence from her family at the time. Best corrected vision 612, but couldn't quite read the necessary requirements of reading a number plate from 20 meters in the UK, so struggled slightly more. And you can see now more looking at the quality of her vision, so looking at the point spread function that we get from the RST, and then the AI representation of cell visions. You can see the difference between the two eyes, and you can see she's going to suffer a lot more dysphotopsies in the right eye and the left eye, which we would expect from that level of keratoconus. We'll see here from the video now. So the channels created, you can see from the ATOS channels there, you just go into them and the channels open very easily as if it's a lenticle from doing lenticle extraction. I now use a curved instrument, which is far easier than actually using a lenticle separator, which I was using at the start. But opening up the channel, but you can see with the ATOS, the channels open very easily after the procedure, and then you can then insert the tissue after that. And again, even with what we're trying to do here is try and minimize the channel width as much as possible without making our lives too difficult. We get the tissue in the correct plane and the correct place, and we get the effect we want, whilst also making it surgically relatively simple. But you can see from this case, it has been sped up, obviously. But we really get some positioning. And the good thing with CAIRS is that you can actually then reposition the actual tissue at the time of the procedure, but also if you're not happy with the outcome, it actually gives you the opportunity to be able to come back at a later date and actually even several months later to actually go back in and manipulate the tissue and move it to actually improve your outcome. So there's that case there, and you can see how it wears. There's there because it's only day one, so you can see the effect we're having. So where are we now? So herniated visions, they're improved in that right eye from 360 to 615, which for one of my early cases, I was delighted with and thought, okay, fine, this offers massive reassurance that actually this is a way forward and it's a good treatment coming. And so we can see now anterior axial curves, the anterior tangentials, which are always the curves that people don't like to show because there's no hiding from them because they show the real data. And you can see the post-op tomographic effect of both of them. So we've still got a regular astigmatism in the center there, but actually we've got a good improvement in her corrected and uncorrected spectacle correction. And you can see there over 17 diopters of regularization, which is very common with CAIRS to see that level of regularization. So the next case I'll show to you is a 44-year-old Caucasian male. This is someone that I've done combined treatment with. But you can see he's a more complicated picture and one that we had to unpick at the time, but had strabismus surgery, been patched as a child, was known to be amblyoptic in the left eye, but we didn't have an idea of how amblyoptic that left eye was. So there was an element of surprise with us there. Again, similarly contact lens intolerant. And he came to us with corrected visions of 636 and 696. He came with his newborn child that he'd just driven to my clinic. And so we had a very difficult conversation to say, look, unfortunately, you don't have driving vision. You can't drive your car home. But he then became highly motivated because that impacted on his ability to be able to work and his ability to be able to safely transport his family around. And so we agreed on a plan with him. First step, doing CAIRS. Sorry, that was in the left eye. This is the right eye. So I did a topo-guided treatment to regularization of this eye, the less severe one. And in my hands, I get more predictability. And I've got a good handle now of the hundreds I've done of being able to gauge where I'm going to get with a final result with the 1050 RS. And so we decided with the left eye, which is the more severe eye, to do a CAIRS first, knowing and telling him preoperatively that this was going to be a two-stage procedure. I knew I wasn't going to fully correct his cornea with the first step, and so I knew that I would have to then do a second step with the AMARIS to be able to fully treat him. You can see again here, his uncorrected visions and his quality of vision, and he's got 624 best corrected binocular vision there, so well below the legal limits in the UK to drive. So first step, there's his CAIRS in situ. And what we can see here, his pre-ops anterior axial curves and the anterior tangentials. And you see, again, with a difference map, we've had a similar amount of regularization. So around 17, just over 17 diopters of regularization. So a great result. Has it got him to the point that we need to get him to? No, but predictably we knew that before we'd even started, and we knew we'd have to do a second procedure. So he was very prepared. So then he knew he was going to have the laser procedure. So in him, I waited 4 months before moving on to doing the laser procedure until I could demonstrate that we had as much stability as we could from the segment we've inserted. And so at that point now, he's got a corrected distance vision of 618 in the left eye. But we've actually, through motivation, managed to get him into a specialist contact lens in his right eye, which he's actually tolerating. So we got him into an iPrim Pro contact lens in his right eye, and he tolerated that very well. So actually, it got him up and about and functioning. And it's something that I do quite regularly with my topo-guided treatments as well, to actually fit contact lenses pre-topo-guided treatment, then do the actual treatment itself, and then you get the contact lens return, and you get the second one and just change the power of the contact lens when you've confirmed the fit. And then you can actually keep these patients seeing through the several month process of actually regularizing their corneas and improving their quality of vision so they can keep functioning in life. So we can see the topo-guided treatments. Now, this is your very classic problem you have with these patients, and particularly with CAIRS patients. You can see you don't get the rings you need to be able to export to be able to put into the AMARIS. You don't get anywhere close to having the number of rings you want to be able to have. So in these cases, what I'll quite often do is I'll do a PTK treatment first. So I'll do a standardized PTK, and in this case, I did 80 microns with the epithelial thicknesses there of 67 and 69. And then immediately go back and do a stromal map on the MS39. So put them back onto the MS39 immediately afterwards and then do stromal maps. And then you get a much more reliable map having taken the epithelium off, and actually then you can then start to get a good idea. And so then what I've done is then built a corneal wavefront driven protocol through Foresight and through the AMARIS. And then we can then see the effect of doing that dual treatment. So here he was preoperatively with his unaided vision of hand movements in this eye, correcting to 696. This is his worst eye. And obviously this is an amblyopic eye, so we don't know where his final visual potential is in this eye. But after the first step, the CAIRS, we got him to 648 and 618 corrected. But you can see after the second stage, we're still at 612, but actually his pinhole vision is not improving beyond that. So we think that's probably the limit of his amblyopia in that left eye, because we can't get him to improve beyond it. But you can see the effect then of having a stage effect. And then we can see now the improvement, hopefully, and you'll see the improvement in his quality of his vision with his AI generated on the ICRS plus his point spread functions. And you can see by the treatment, you can see how you've improved his quality of vision by having that stage procedure and having the 2 steps. Thank you.
Thanks very much, Kieren. With the topo-guided PRK, do you do that after, with a CARES segment, are you concerned about treatment over the CARES segment and extrusion melt? And what are your guidelines that you use?
Yeah, so in these ones, when I'm doing a staged procedure in this way, I'll deliberately implant the CARES below Alien's 250. And so that one I actually implanted down at 350. So I knew I had enough room above to try and reduce that. The thing we don't understand fully yet is the effect of that anterior stromal compaction that we're seeing with all of these treatments, and the risk, therefore, of that in the future of then potentially getting an extrusion. But to date, it's described, but I haven't had it in my own practice.
How long do you wait for stability after the CARES segment to then do the...
So because of his individual need, we did it relatively quickly. So I did it at 4 months because he was just desperate to get back to functioning vision again. So, with counselling, with explaining to him that actually he probably will get some more tomographic effect and change over that time, but he was just very keen to move on to that next stage. And so I did it sooner than I would ideally have done it. Ideally, I'd like to wait 12 months really to see an effect. But actually, patients quite often will understand the risk of doing it sooner, but reaching that end goal is more important. And what I'll do quite often with the second treatment is combine it with cross-linking, which again may be controversial in some hands, but I'll combine a cross-linking with the topo-guided treatment afterwards, and then obviously avoiding using mitomycin C, because the combination of those then increases the risk of haze.
This coming also, I have one question there, because you mentioned cross-linking. So do you cross-link also sometimes the CARES implant before implanting, or you wait and see?
So I haven't. So I think we've not got to a stage yet where we've got anywhere close to having a very reliable nomogram with any of this. And so I think what you're actually doing there is introducing an additional element of unpredictability into it. And the thing that happens with the CARES is it is so biocompatible that actually it does mold into that space. Now, when I'm doing the cross-linking with the topo-guided treatments, I deliberately use a 30 milliwatt protocol, and I use a 1 second on, 1 second off. So it's an 8-minute protocol, because we know from our own data of now having done several thousand that actually that gets far less flattening, and the actual flattening effect at 12 months is very stable.
Great talk. Thank you. When you're doing the 2-stage laser treatment with the PTK followed by the topo treatment, what's the time interval between the treatments?
Sorry, say again. Sorry.
What's the time interval between the treatments? Or is that all?
Sorry, which treatments? I didn't hear which treatments. Sorry.
The PTK followed by the topography-guided.
Oh, right. So they're literally they're medium. Yeah. So they're all on the same day. Yes, it's the only way I can get the stromal maps, because if I let the epithelium remodel again, I'll be back in the same situation again. And I found actually with some of the topo-guided treatments I do as well, I'll do exactly that same process. So you can find that you can actually, with the AMARIS, be far better tissue saving actually by staging those treatments and actually doing a treatment, rescanning, doing a stromal profile, and then actually doing a stromal driven protocol, which is what we'd all like to do from the outset in an ideal world, but doing that in a staged way on the same day.
Any tips with the acquisition? Is it just a bit of lubrication and then?
Yeah, exactly. Yeah.
I have one last thing. So CAIRS, talking about CAIRS, do you see the potential? Because of course it's working different than the rings. So of course the nomograms, all of them, what we have, they are based on this mechanical strengthening. So how we can think out of the box? Is there the potential that we have that we can provide bigger optical zones for the patients later? Do we have to think more how much volume we're adding instead of which diameter we're adding?
I think it's all of those actually, and I think we need to be conscious of each of those individual variables. So I think it's the volume, it's the width of the segment, and the thickness of the segment from there. But obviously the optical zone plays a massive effect in it. I think in my practice, I can see myself moving away from the way that some others are doing it, in the fact of tightening down that optical zone so you can actually get a greater effect with the CAIRS, and accepting the fact that I'll have a potentially less effect with that CAIRS, but actually doing it as a staged procedure, because I find that at present, with the current nomograms, the AMARIS is a far more predictable tool for me doing a topo-guided treatment effect than I'm going to get with CAIRS at this present time. That may change in time as the nomograms improve, but at the moment, that's where I am. I get very predictable, very reliable results in the 1050 RS that just, pushes me and sways me towards that in the several hundred we've done.
Perfect. Then, thank you much for your coming. Thank you much, Kieren. It was a pleasure.
Thank you. Thank you for having me. Yeah, thank you.